We are live, please.
So, good evening, all, and good evening to all the AOS members, as well as to the speakers, panelists, chairpersons, everyone who have joined today's Myopia webinar. Since I'm flying, I will just request today's moderators, Dr. Parikshit and Dr. Biputhy, to carry forward the proceedings without much. They are responsible for creating such a wonderful webinar with such a star luminaries today. So, over to you, Parikshit and Vibhuti.
Good evening, Prashant sir, and thank you very much. And good evening, everybody. So I welcome you all to the yet another AIOS ARC webinar, and this time the topic is myopia. We have a new outlook for an old problem presented in a platter with you in front of you with a galaxy of chairpersons, esteemed speakers, debaters, and its respective discussants. So without any further ado, I'm gonna introduce the chairpersons for today's webinar. Dr. Pradeep Deshpande, Professor Naina Poddar, Dr. Jaspreet Sukhija, and Dr. Subhash Dadia. I request Dr. Parikshit to introduce the chairpersons, please.
Dr. Pradeep Deshpande has been the president of SPOCI. Professor Naina Poddar is an eminent pediatric ophthalmologist based in Mumbai. Dr. Jaspreet Sukhija is a professor at PGI Chandigarh, and Dr. Subhash Dadia is the director of NAMC and Guru Nanak Eye Care Center. So I think let us start with the talks first, and then perhaps we can have discussions at the end. So may I request the first speaker to please start the proceeding?
Yes, sir. So our first speaker is Dr. Ramesh Kekonia, and he'll be talking on is the myopia pandemic real? So he hardly needs an introduction in the world of pediatric ophthalmology. Dr. Ramesh Kekonia leads the Child Sight Institute and Children's Eye Care Center at LV Prasad Eye Institute, Hyderabad, and is an internationally recognized voice in pediatric ophthalmology, strabismus, and childhood myopia. There could hardly be a better person to tell us whether the myopia pandemic is truly real. Over to you, sir.
Good evening. Am I audible?
Yes, sir. You're audible as well as visible, and your slides are visible.
Okay. Thank you very much for this invitation.
We can see it, sir.
Yeah, I'm happy to be here. The first talk is a bit of a controversial topic, but I will explain it with a few of the slides, and I will try to maintain the time. So these are some of the financial disclosures. Some are related to myopia. I'm the scientific advisor for Essilor Luxottica. I do not get any financial support, but I just advisor for that, and rest of the things are not related to myopia here. So when you look at myopia, the management, it improves, the prevention aspect, communication aspect, risk assessment, and it got three things. Sometimes people confuse that. This is a beautiful article from Ian Flipcroft. He has written myopia control, myopia correction, and monitoring of axial length and refraction. So it includes it encompasses everything. It's not just about myopia control. Most of the time when people speak, they speak about myopia control. So myopia management is much more than what it really appears to be. If you look at this chart, I think this is the only important slide of my talk, which is talking about everywhere in the world, what you are at 2020, over a period of time, it is improving. The prevalence, current and the projected myopia prevalence by region. You can see from each region, somewhere it is going up till 58%, 60%. Some of the places like Africa, it is going from 8% to 30%. So children are developing myopia at an earlier stage. There is an increased risk of secondary conditions. As you know, most of the leading cause of visual impairment and blindness in many countries, as you can see in the entire world, you can see, and it increases the economic burden. This is one of the very, very important article from Brian Holden. He's no more. But this is the global prevalence of myopia and high myopia. temporal trends starting from 2000 to the next 50 years, that is 2050. As you can see here in this slide, 2000 to 2050. You can see in each of those, if you look at our Asian area, it's almost touching 62%, and Asia Pacific highest income countries, it can go up till 66% of the population is going to be kind of myopic. And on an average, half of the population will be myopic. But it all depends upon, we have the till 2020 data. You can see, for example, Asia Pacific, it grew from 46 to 53%. If you see Southeast Asia, it grew from 14 to 28. It's almost double. This trend is very, very important. If you look at Southeast Asia, it's not so much. It was already high, 33. It went up till 46. So this is what exactly what is looking at. And if you see the global one, it's going up till 50%. And this is one of the article from Pawan. You can see the predicted prevalence from 2020 onwards. If you really project it the way it is, what you can see in the red colored box or the round object there, you can see it can go up till here by 2050. It's almost 48.1%. But here's the thing, from 2010 onwards, or probably 5 onwards, there are a lot of myopia management or a control options are available. But 2020 onwards, whether it will take the same trajectory or, more and more people know about myopia control, whether it will plateau, we don't know. That's why it's definitely a pandemic. Whether it will remain as a pandemic, we do not know. And you can see the trends between early myopia going up till prevalence in 2020, 2030, 2040, and 2050, what you can see in this particular slide. High and high younger age group patients will have more and more myopia, and as they grow old, it will be less. But one thing is very, very important. If you are a myope once in life, you are a myope for a lifetime. This is something, sometimes hypermetropia can reduce, but this is something. So 50% of the world population, if the trend goes. But what is the most important factor which controls is the environmental changes, and to some extent, and in some cases, a genetic modification as well. Why is myopia increasing? Definitely because of more and more academic work, digital devices, people are indoors, more and more people are inside the house, and the intensity of education is increasing year by year. And obviously, urbanization, and there is a key message, at least more equal to 2 hours or more than 2 hours of outdoors is protective before the child develops myopia. This is something we need to remember. And during COVID, definitely you can see home confinement led to significant myopic shift for children between 6 to 8 years. And we have this myopia. Can we prevent it is what we need to think, so that the projected score or the projected prevalence can come down. Second thing is, can we identify the high-risk children and put them on myopia control? And can we reduce this pathological myopia to the minuscule amount is one thing we need to. Coming to the Indian scenario, it varies from 13 to 22%. These are all you have to see. Population studied is always school children and adolescents. The other data is not available, but if you pull this data around, it's within 10% of the people are myopic in the school. But the rural India is doing much better. But there are multiple studies. I think Dr. Rohit has NIM studies and STEM study from Tamil Nadu. And Eli Prasad did the APET study, and we also screened the last year 1 lakh children. Even in that, the prevalence is around 10 or 12%. So whether it will go up, there are a lot of things we can do, and we should worry, because depending upon the age of the child or age of the patient, where they are, they have a chance of, they should worry about retinal detachment, if they are old, cataract and glaucoma, if they are really elderly, myopic maculopathy. And if they are very young patients, they have to think about, can you reduce the refractive surgery? Having a refractive surgery for -6 or -9 is different from -3, and they may have to make an occupational choices at early. So it affects every domain of the population. And the way forward is to prevent this pandemic or the projected score to come down. We need to make an early identification by school-based or a home-based screening. More and more teachers and the parents should be educated about it, because digitization is growing like anything. At any given point of time, a child will at least spend 1 or 1.5 hours per day on the digital. So can we provide more and more access to myopia control? And obviously, research innovation is not enough. At the policy level, at the government level, can we do something? Then we can really reduce this growth chart going up. So that's the thing I would end with. Today's child with myopia should not become tomorrow's adult with preventable blindness. Can we prevent that growth chart? We don't know yet. But this way forward, we can do something. All of us on this call, or all of us, our contacts, can really affect or make a change in at least one of those, if not all of those. We can do it. I would like to invite you to this Pediatric Ophthalmology and Strabismus Network meeting in Bhubaneswar. And if you want to know more about education, WSPS has created this QR code, which has got a lot of educational tools. Thank you very much, and I appreciate this invitation and to be a part of this wonderful webinar. Thank you very much.
Thank you so much, sir. It was a wonderful talk. I would invite the chairpersons for a quick comment if they are available. Dr. Jaspreet Sukhija, if you have anything to say on this about this.
Yeah, thank you. I mean, no doubt it's an eye opener of what's happening around the world, and the way things are increasing, and what we need to inculcate in India, especially the policies. What is really put forward is collaborating with especially schools. I mean, school screening and interventions. So that's the need of the hour now, actually, because see, different ethnicities, different, I mean, countries where they have a different population, those things are really different. But actually, if you want to put in the real world scenario, our country is different. Okay, so getting it actually into where it's really required, like the practical aspects of it, so like getting it onto the schools, is very important here.
Thank you, Dr. Jaspreet. Now, we're moving on to the next talk. Our next speaker is Dr. Jitendra Jethani, and his topic is pre-myopia, why should we recognize it? So Jitendra Jethani is one of the innovative minds in Indian pediatric ophthalmology and strabismus, combining busy clinical practice with research and practical innovation. As director of Baroda Children Eye Care and Squint Clinic, he brings enormous experience to a subject that asks us to identify risk even before the established myopia appears. Over to you, sir.
Thank you so much, Dr. Vibhuti, and I really thank Prashant sir, Parikshit sir, and Dr. Rajesh for giving me the opportunity to speak on something which already, as Dr. Ramesh rightly said, that what can we do to prevent children from becoming myopic. And the most important point is that how much we can delay the onset of myopia, because most of us understand that once the myopia starts, there is a huge difference in the outcome, which means that younger the children will start on myopia, more more and more diopters will keep on adding, and every diopter really counts. So understanding pre-myopia before the lightning actually strikes. So what exactly is pre-myopia? We now have got accustomed with the term pre-myopia as a refractive state where we talk between plus 0.75 to minus 0.5, where, with some risk factors like age, baseline refraction, parental myopia, we do classify them as children who are at risk of developing myopia. So this is a stage which is just before the onset of myopia and the progression of myopia. We all know that there will be a lot of children who may not get converted into true myopes, and it all depends on serial follow-ups. And we can use some calculators. Ramesh was talking about Ian Philcroft, who has designed his own calculator, Ocumetra. But that is a paid version. This is a free version, BHVI, which is available from Holden Vision Institute. We can go inside this, we can see, we can put certain data. Similar calculator has also been developed by LVP, which gives you a risk analysis of which patient may go in for becoming a myope. So for me, any child who loses his hyperopic reserve quickly between the visits, and if there is a history of near work, and if parental myopia there is a history of parental myopia, and if he loses, and if his axial growth is there, you club them or you classify them as pre-myopes. Now, whether to treat the pre-myope or not depends on a lot of factors, and we'll see that. But this is as per how to classify the pre-myopes. And this is how you can keep them in low risk, medium risk, and high risk. So you can see as you go towards younger the age, more myopic parents, more time spent less time spent outdoors, more time spent for near work, and obviously progression over last year. How much was the progression, and how much was the axial elongation over a period of follow-ups and over a period of time? So obviously, what is the importance for this, for diagnosing or for finding out or for doing this all hard work? So we all understand that whenever a child is younger and becomes myopic, there are more number of years which are available to grow into more and more axial elongation and higher higher dioptric power at the end of adult age group. We know that the ceiling is 16 to 18 years, so we definitely know the cutoff at which it will stop, most of them. But if it is younger onset, the progression or the final endpoint will be much higher. So each earlier year of onset is associated with approximately a risk of 0.75 to 1 diopter more or increased or final myopia refraction. So even if we can delay the onset by 1 year, could lower the final myopia level by 0.75 or 1 diopter of myopia control. So we also know that, whenever we talk about myopia, in the gist of it, we do say myopia, but we only talk about axial myopes. So in non-myopes, axial elongation is more rapid in younger than in older children. And there's a broad range observable with emetropes. They would be, so only axial length can also tell you a lot about it, but you cannot just on the basis of axial length classify them as pre-myopes. So you have to take into consideration all the risk factors. So there are these are the risk factors. This is how you can clinically you can do a risk stratification that, if your dioptric power is very low, like very close to emetropia, declining hyperopic reserve every time the child comes to you. Nowadays, astigmatism, there are multiple articles. We are discussing it at ISCRS also, that astigmatism has become more and more important, especially for pre-myopes. So what they say, and I would be covering in a couple of slides that also, that if you have a higher astigmatism, the chances are that you may go in for a myopia rather than stay hyperopic or stay metrope. Rapid axial elongation in the preceding years and a history of parental myopia, all these are at a higher risk of myopia onset and progression. Astigmatism, as I said, has become a risk modifier in pre-myopia. And this is the theory. that if you have a steeper vertical meridian than horizontal, this is more consistently associated with higher myopia if it is already myopic. And the vertical meridian puts focus in the horizontal plane, which is steeper, and so the peripheral because of peripheral defocus, the eyeball size would grow. So these are some of the studies, some of the data where they talk about giving glasses to these pre-myopes. And these are the thresholds and progress risk factors in pre-myopes who have astigmatism. So against the rule astigmatism versus with the rule astigmatism, believe that ATR may progress faster because they have more horizontal hyperopic defocus. Pure sphere versus sphere plus cylinder, the patient with having cylindrical power, they progress much faster. And this is the myopia progression cutoff, that if this much amount of dioptric power was progressed 1 year back, there are chances that this particular patient would go in for pre-myopia. So that brings us to the point, why should we look for pre-myopia? So this slide, which was published by Review of Myopia Management last year in June, this sums up why every diopter or why every 2 or 3 diopters do matter. If you see that, if the eye disease is at 2 diopters, myopic maculopathy odds ratio is 2.2. But if it goes to 4, it becomes 9.7 times higher. So this is the impact of how and why we should delay the onset of myopia as much as possible. And why should we act early? Because every 1 diopter myopic shift prior to the onset becomes very, very important. And this is very much clinically relevant. Most of these patients would have a pre-myopic acceleration window just before the actual myopia sets in. And this is again same that, if the child is between 6 to 7 years and this is the pre-myopic threshold, we should wait and try to talk about lifestyle intervention. I think lifestyle intervention holds the key in these pre-myopic children. And this is the impact, as I was talking about, what is the impact of delaying this onset. So if we delay the onset at the age of 6 years, the chances of high myopia onset, if the pre-myopia or myopia starts at 8 years, so if you can bring from 6 years to 8 years, if you can delay the myopia for 2 years, the kid may end up with 4.25 rather than 6.5. So that is the impact of delaying myopia onset by just 2 years. So these are some of the cases where we could initiate in pre-myopes. You can see that patient came to us with a hyperopia of +1 and with an axial length of 22.16. And we started when he became a very early myope, -0.5. None of the parents were actually myopic. So, but the kid was an avid reader and had lot of screen time, very less outdoor activity. And this was, I think, with atropine. This was in 2023. We started with atropine, and we could slow down his progression. So both the second case is basically a classic pre-myope with parents. Both the cases do show that whether parents are myopic or not, I think more important is near work, outdoor timing, and progression. So if you can document that there is a gradual progression over a period of time and patient is moving and losing out his plus power very quickly, and he is going towards becoming a myope, you can start or initiate the treatment at that point. You can see with atropine, we could achieve a plateau for a long time. And again, the kid became pre-pubertal, was around 11 years, and again started progressing. So this is the final slide, just to sum up everything in myopia control. So in conclusion, most of the patients would just require 6 monthly reviews, but we should keep our eye open. We should keep telling them that they may go in for myopia, and once they go for myopia, the progression would be much quicker. We should tell them to increase outdoor time, reduce near work, and of course, we can use myopia control measures if there is sufficient evidence for that particular patient, that particular patient is going to progress. Then we can use some modalities to delay the onset of myopia. So thank you so much for the opportunity.
Yes,
Thank you, sir.
Thank you, Dr. Jitendra. Wonderful as usual.
Thank you, sir. Thank you so much.
Now, I would like to request Dr. Pradeep Deshpande, sir, to give his expert comments if he is available online.
Please, there.
Okay, probably he got offline. So we'll quickly move on to the next
Hello.
talk. Our next speaker. Hello.
Yeah. Dr.
Yeah.
Jitendra's talk was excellent.
Yes, sir.
He has
Please
done
go.
a lot of work on pre-myopia. I would like to ask one question, whether the anatomical myopia, we call it anatomical myopia, the minus 0.25 or 0.5, in such cases, what we should do, whether we should prescribe or we don't, as per the asthenopia, or is it, if you prescribe the glasses, does it will prevent the progression?
Sir, if the power is more than 0.5, that is what is supposed to be. This was discussed, I think, in last. I think this was discussed last year also, that if the power is more than at least 0.5 diopter is the minimum that would account for change and prescription. That would be the minimum that we would give. Normally, I would not prescribe minus 0.25. Having said that, if the patient has moved from pre-myopia or from hyperopia to minus 0.25, I may still not prescribe it, but I would still tell the patient that, this your child is going to become more and more myope as the time goes on.
In such cases, if you try to improve the general health of that child, including all proteins and multifactorial deficiencies, is it possible that the anatomical myopia will not trouble or it will not go? In few cases, not in all.
I don't know, sir. Maybe I have no idea that whether food or the nutritions would play a role.
Because nowadays, because of different viral infections, there are so lot of fatigue and weakness in children is found and in.
You're not audible, sir.
Your voice is breaking.
Okay, sorry. Is there any in cases where there is post-viral weakness? In these cases, is it audible?
Yes, sir.
Yeah. In these cases, I have been observing that the progression of myopia is a little faster. And then you cannot compare with different other children also. So we have
I
to
think
take care of their
that is
general
true.
health.
We should not compare pathological myopia from, as Dr. Rohit repeatedly says, that this is all about school going myopia, and this should not be clubbed with any other cause for myopia, syndromic myopes, and other cases where you especially know that this is because of some cause and effect relationship. I don't think we should consider them as cases where these all drugs and these things can be used.
Okay. Personally, I feel that nutrition has a definite role.
Definitely.
Thank you, sir. So we'll move on to the next speaker. Our next speaker is Dr. Shweta Chaurasia, and her topic is consequences of uncontrolled myopia. Now, Dr. Shweta is an academician, and I can say that from my personal experience because she was my senior at RP Center. She's a pediatric ophthalmologist from Advanced Eye Care PGIMR Chandigarh, with interests spanning pediatric ophthalmology, strabismus, neuro-ophthalmology, and myopia. Her work in childhood myopia makes her ideally placed to remind us that myopia is not merely a refractive error. The real concern is what happens when progression remains uncontrolled. Over to you, ma'am.
Thank you for the invitation. Is my slide visible?
Yes, ma'am, it's visible.
It's
And you're
visible.
audible.
Yeah, thank you. So, good evening, everyone.
Doctor, can I just interrupt? You need to change it from presenter's mode to the normal mode, slideshow mode. Use slideshow on the top if you can just change it to. It's actually the presenter's mode. We can see the notes also. Once you've done it, you can change it. Just go slideshare. Just do slideshow on the top.
Ma'am, next to animations, you have slideshow on the top bar.
Yes,
Yeah,
perfect.
it's
Perfect.
Yeah.
yeah. So good evening, everyone. So I'll be talking on the consequences of uncontrolled myopia. It's not moving. Yeah. So we have already talked about the epidemic, the stats. So I will directly move ahead. So in India also, we have seen a 120% increase percentage in rise in the urban adolescent myopia. And that is at a skyrocketing speed. So first, before we talk about the consequences, I would like to define what is uncontrolled myopia. So if a child is progressing more than 0.5 diopter per year, or if a child has already attained -6 diopters, or now is showing the signs of pathological myopia, all comes under the umbrella of uncontrolled myopia. So it is not the diopter that damages the eye, but the axial stretch, which is the primary driver of disease. And if the eye reaches 26 millimeter danger zone, the risk climbs sharply high. So the anatomical toll of elongation spans the entire ocular structure. And we will be discussing the spectrum of ocular consequences one by one. The posterior staphyloma is a outward bulging of the sclera at the posterior pole. And OCT surveillance is important even in adolescents. The dome-shaped macula is the inward bulge within an outward staphyloma, and it is linked to subretinal fluid and CNVM risk. Myopic maculopathy, the meta-analysis of pathological myopia has defined various stages from C0 to C4. The C0 and C1 are the benign ones, whereas C2 and C3 and C4 are the ones which constitute like diffuse chorioretinal atrophy or macular atrophy, and these are the plus lesions. The plus lesions also include lateral cracks, fugue spots, and myopic CNVM. The cracks is break in Bruch membrane, and fugue spots is pigmented scar. Myopic CNVM is the primary cause of CNVM under age 50. And this is the 5-year incidence of myopic CNVM is in high myopes is 5 to 11%, and it is 90% in untreated high myopic eyes. The peripheral degeneration is constituted by lattice degeneration, retinal breaks, which are often asymptomatic until RD develops. So the RD risk in high myopia is tenfold. The myopic traction maculopathy is about 30% in staphyloma eyes. The traction splits the retina into layers. This is often silent, and OCT is important to monitor. High myopia severely distort the standard diagnostic assessment, and the glaucoma risk is 2 to 3 times. The tilt to this distort the standard assessment, and thinner RNFL skews the normative databases. There is impact on the lens as well, and the nuclear sclerosis cataract risk rises. Onset is 10 years earlier than emetropes, and biometry and IL calculations are significantly harder. Amblyopia is a well-known established thing in the high myopic cases. There is risk of ametropic amblyopia. And one of the data by the rural Telangana school study shows that 69.2% of amblyopic cases had underlying myopic refractive error. Also, unilateral progression is a hidden amblyopigenic threat, and one should not miss the worsen eye. Strabismus is one which is associated with high myopia. The Sydney myopia study have shown that 25% of children with myopia had strabismus compared to 1.9% of emetropes and 4.3% of hyperopes. And most of these cases were IDS, and the risk has increased with early onset. There is also heavy eye or sagging eye syndrome, which is related with high myopia. And there is inferiorization of lateral rectus and nasalization of superior rectus, and there is superolateral bulging of the globe, which causes a sagging eye syndrome, and this is seen in high pathological myopia. So the inevitable cascade of structural failure leads to irreversible vision loss and psychosocial impact. So the bottom line is that this is the leading cause of irreversible blindness. This is the top 3 cause of blindness in working age adults. There's bilateral damage to both central vision, and there is a lifelong risk which continues past refractive stabilization. The Saxena et al. Study has shown from the data of 1,297 myopic school children patients that 35.1% of children presenting with visual impairment were myopic. Now, the clinical measurements are only a fraction of the disease. Beyond the diopter, we have to see there is a psychosocial and economic burden of the uncontrolled myopia. So the first functional consequence is in the classroom performance, and high myopic children shows lower scorecard. They have difficulty in seeing the blackboard. There is reduced lesson engagement. In a study in rural school in China, there has been seen that the impact of correcting myopia on academic performance was greater in classroom that relied heavily on blackboards. The second functional consequence was sports participation, and it is seen that there is difficulty in sports, reduced peer activities, and reduced outdoor time. The quality of life also suffers, and the children suffer from lack of self-confidence, social isolation, and anxiety over absolute reliance on the correction for the basic functioning. There's intense dislike of the thick glasses, and also the skin on the bridge of the nose gets damaged due to heavy frames. There's cosmetic anxiety, there is teasing, fear of peer bullying, and discrimination and isolation. It has been shown that high myopia and keratoconus result in statistically identical quality of life impairment. So the invisible loop of academic frustration, lowered self-esteem, peer teasing, spectacle avoidance, which has been shown as high as 24.7% children non-compliant with glasses, leading to worsened visual impairment, and the vicious circle continues. And another functional consequence is spectacle burden, which according to the one studies has been estimated to be 4,600 median annual direct cost per person, which is quite high. So there is a compound trajectory of uncontrolled myopia in every age group, whether it is 7 to 12 years, the classroom age group, where there is academic loss of learning milestones, 13 to 18, where there is a social sphere, spectacle stigma, sports exclusion. The prime years of 19 to 25, severe quality of life drops, reaching keratoconus parity in high myopes. And age 25 plus, there is a peak economic productivity loss, which gets escalated because of the myopic maculopathy or retinal detachment risk. There's one of the economic argument about correcting uncorrected myopia, which is estimated that there is $244 billion of annual global cost of lost productivity due to uncorrected myopia, whereas there is only 20 billion estimated total global cost to build infrastructure, train personnel, and correct all visual impairment over 5 years. So treating myopia is not just a clinical duty, it is a macroeconomic imperative also. So the paradigm shift in pediatric ophthalmology has to be from the dioptric focus to trajectory focus. And we have to identify the steepest trajectories of progression, like younger onset, high baseline myopia progression, environmental load, and parental history. So the key takeaway from this talk is myopia is a disease trajectory, not a prescription. Its worst consequences are often irreversible. In children, it threatens vision and development, and childhood is the only window to change course. So when we control myopia, we don't just save vision, we save potential.
Thank you so much, Dr. Shweta. It was a wonderful talk. Now I would like to invite Dr. Jaspreet for his comments, if any.
Yeah, precisely. I mean, the reason why so much importance is being given to preventing the progression of myopia, and obviously now, as Jitendra was discussing, pre-myopia as well. So it's not just not affects the quality of life, but also it's the social stigma, and besides all the ocular complications which come up. And the only thing is, one has to be careful about what we are dealing with. Is it an early onset high myopia or what's a late onset high myopia? Because the whole structuring is different. The early onset is like, say, till about 12, 13 years when you have a growth guided remodeling. Late onset high myopia is when you have a thick sclera, but it's degenerating. So things would be different as compared to what we are dealing with. Because in the present scenario, we're seeing myopia at 12 years, we are seeing the progression at even 18, 19 years. So those things are a little different, but definitely majority are children. And so, as Dr. Shweta has rightly put out things, we need to check the progression to avoid all the consequences which are there, both ocular and social.
Thank you so much, sir. Now we move on to our final talk of the day. Our next speaker is Professor Rohit Saxena, and his topic is Overview of Current Trends in Myopia, Control Impact, and Latest Worldwide Trends. Now, whenever we discuss myopia in India, there are very few people who have actually generated the evidence that the rest of us quote. And Professor Saxena of the RPC, AIMS New Delhi, is one of India's foremost academic authorities on childhood myopia, pediatric ophthalmology, and strabismus, and has contributed substantially to Indian consensus guidance on progressive myopia. Over to you, sir. Please enlighten us.
Sorry. Good evening, everybody. Am I audible?
Yes, sir. You're audible and your slides are visible.
Yes, sir, you are.
So thank you, Bibhuti, and thank you, ARC team, for giving me the opportunity to be here and discussing such an important topic. I'll just kind of shorten the very long title that I had. So it's essentially talking on current trends of myopia management, a lot of which will be discussed in the debates that will come. I unfortunately have no conflict of interest to declare. Just a second, I'll just, again, the slide was not moving.
तो मैं हीट दैट सूप अप मेरा वाला जो है वो जो डब्बे वाला है वो मैं येलो बाउल में वो तो
I may have to
Sumita, ma'am,
just click on the screen.
If you can mute yourself, please.
Sorry?
Doctor Agarkar, can you mute yourself?
येलो डब्बे में हाँ
रोहित सर, एक बार स्क्रीन पे आप जब शेयर करेंगे, just click on the screen on the PPT.
Yeah, I put share now.
Yes, please.
It's visible now.
Yes, just click on the PPT. एक बार slideshow में डाल के, just put it in a slideshow mode.
Yeah. Okay. Thanks.
All good.
Thank you.
All good.
So I'll hide the controls. So childhood myopia, we've just discussed how significant the problem is, and the prevalence is increasing globally with association of vision-threatening conditions. We've talked about the importance of early intervention, because long-term slowing progression can reduce long-term complications. And of course, I'll be discussing a bit about the emerging strategies that are there. Just before I go on, I wanted to thank AIOS again for helping us run this nationwide prevalence of refractive error and effective refractive error among school-going children, the AIOS See India project, that we hope will be doing 60 districts all over the country, randomly selected. In association with the ministry, we hope to generate nationwide data which will tell us about refractive errors and particularly myopia in the school-going age group. So we look forward to this information as we proceed with this study. A bit about the atropine therapy, which is probably the single largest accepted treatment, and 0.01, which is the most accepted low dose concentration. Just still the fact that 0.01 is still not FDA approved, while the good news is that FDA has reconsidered the application to decide whether it can be approved or not, but it still remains unapproved in US and many parts of the world. We are, of course, happy that in India, we also have now 0.05% available, which has shown to be more effective all across ages and ethnicities as compared to the 0.01. And the Mosaic study showed that 1 year of 0.05 actually is equal to 2 years of 0.01 in its control. Unfortunately, the AEs are significantly higher with 0.05, and we are seeing some amount of children who are not so comfortable or tolerant to 0.05. So currently, my role of 0.05 would be in those who have a very rapid baseline progression of 0.75 or more diopters untreated, and those who have a moderate response to 0.01. So if they continue to progress at close to 0.5 despite on 0.01, I would think of 0.05, or if they are a rapid progressor, it becomes an indication to start the higher concentration rather than the lower one. We are looking at emerging studies with 0.025 and 0.05, and we hope that in India also 0.025 comes as a possible alternative. We've evaluated 0.01 for high myo because currently most studies had looked till only 16 or 17 years of age and only till 6 diopters. So we evaluated 6 to 12 diopters, and we found not only a significant reduction in myopic progression, but we also found it to correlate well with the axial length change, something that is not seen with 0.01. And one of the possible reasons could be the anterior segment compensation I'll talk about just in a bit. We also evaluated 0.05 for rapid progressors, as I had mentioned, becomes one of the indications. And we found again a very good control or reduction in the rate of progression with 0.05 in these subgroup of children who had a very high rate of progression at baseline. Now, looking into the mechanism of action, one of the things that we found was the lack of correlation between the refractive error progression and the axial length change. And the axial length seemed to elongate a little more than the refractive error. And that was a dichotomy that was unexplained. We did lens power studies in these patients, and we found that the loss of lens power with 0.01 was significant compared to controls and could partly show the reason why this dichotomy is there, and also could actually talk about or give the reason for the rebound we see post cessation of atropine. We also found measurable quantities of atropine in the vitreous cavity in patients undergoing vitreous surgery, and we had put a drop of 0.01 before they went for surgery, and we found measurable quantities showing that atropine is actually reaching into the posterior segment where it is supposed to act. Other interventions, oral or topical, like 7-methylxanthine, pyrazipine, even anti-glaucoma medication or citicoline have been tried, but at the moment, none of them has been found to be clinically useful in treating progressive myopia, though we hope that 1 or 2 of these molecules may come for clinical trial. Looking at the optical interventions, we are kind of spoiled for choice. We have 3 available in India, and the dot technology, which is also hopefully coming soon. All of 4 of them have found to be significantly effective, and the are, of course, comparison, which we compared the 3 types of optical lenses available in India, we found them to be significantly effective. The DIMS and HALT were slightly superior in efficacy to the CARE, but of course, this was very slightly different, and though statistically significant, may not have been so clinically significant. So whatever you are access to, you can use them. Optical interventions are very significant. The better news is that even better technology of opticals is coming in. Stellest recently launched their HALT Max, which has increased asphericity, increased volumetric defocus, a smaller, tighter, clear vision zone, and they have shown to be 50% more effective than the original Stellest, which anyway were very good. So hopefully we'll see them affordable to most of our children and being effective in reducing the rate of myopia progression. Very, very recently, I think just this week, MyoSmart IQ, the 2nd generation optical interventions by Hoya, have been introduced. Again, they are supposed to be higher effectiveness and virtually negligible progression after 6 to 12 months of therapy. And again, as we get more and more experience, we realize how well they do. This is just another set of lenses that has been evaluated, the dual side composite defocus spectacles, popular now in China. The studies have shown them to be fairly effective. We await their availability in India. Soft contact lenses also are found to be extremely beneficial, although again, our experience with them is moderate or limited, and they are found to be fairly effective. Ortho-K has the advantage that it gives you spectacle-free daytime wear, daytime vision, and that is useful, though again, Ortho-K is a little challenging because of the corneal related effects that we have seen in our population in India, but still that remains a fairly acceptable intervention in older children looking for spectacle-free daytime. Combination is the next important thing coming with pharma as well as optical, and they are the best combined together, atropine with either spectacles, ortho-K, or multifocals. But there are still challenges. How long will you treat? What will you discontinue first? And for how long therapy? We know myopia is a lifestyle disease. We've talked about it repeatedly. And it's very, very important to know that near work and light deficit environment, which is predominantly indoors, are responsible for this. And a change in lifestyle is essential. And outdoor activity and outdoor light has been shown to have significant effect on myopia progression and axial elongation. In fact, every progressive hour of outdoor activity per day has a significant reduction in the risk of progressive myopia. Pre-myopia has been discussed, and just bringing it up here to say that the role of outdoor activity and lifestyle intervention is the best for pre-myopia because atropine is still equivocal evidence, and lifestyle changes, if implemented early, would be the most effective in long term. Red light therapy is again effective in the studies done in East Asia, particularly China. Unfortunately, not available, but they are found to be very, very effective. One of the downsides is that there is possible rebound and retinal changes or foveal burns, which of course has been seen in a couple of cases, but more evidence is required for either. Dr. Pradeep Deshpande mentioned about dietary modifications. Of course, it's always good to have a generally healthy diet and lifestyle for the child. But at the moment, there is no direct evidence of nutritional issues with progressive childhood myopia. We know that AI-powered predictions are now coming in. We have been working on axial length, age, and gender, making a huge difference to the rate of progression of myopia, and we hope we'll be able to get some predictive modeling very soon. The most important thing or things in the horizon would be a genetic understanding of progressive myopia that can enable proactive counseling and personalized intervention strategies as we identify more and more genes that may be responsible and modified. So future clinical practice would be data-driven clinics, integrating the community-based evaluation and therapy with myopia prevention and progression, personalized treatment plans, and of course, the most important thing, policy changes, especially among the government and schools. Guidelines have come. We have just coming out with the 2.0. These were the earlier ones. The 2.0 are going to come. But the more important things is to harmonize the guidelines internationally because of the variation in the country-wise availability of treatment, prevalence rates, and lifestyle. And therefore, it's important to have global harmonization of guidelines and have a little global experience, which we hope comes up soon. We know myopia is an emerging public health problem. Awareness is the most important in the next generation. We know lifestyle modification, myopia spectacles, atropine really work along with ortho-K and soft contact lenses, but lifestyle still remains the most important thing we must always stress about. Thank you very much for the opportunity.
Thank you so much
Wonderful
for the wonderful
talks.
talk, sir. Parikshit, sir, please.
No, we have had like 4 wonderful talks, and yeah, we've learned so much new. But then there are so many aspects on myopia which are debatable. So let's go on to the debate, sir.
All right, sir. So we'll start off with the debate sessions now. So our first debate is atropine versus DIMS glasses for myopia. So we have Dr. Rishikesh Mai speaking for atropine and Dr. Dipali Gogoi speaking for DIMS glasses. So speaking for atropine, Dr. Rishikesh Mai is an accomplished pediatric ophthalmologist and strabismologist with training at Shankar Nethralaya and extensive experience in children's eye care. Today, he takes up perhaps the most established pharmacological weapon in our myopia control armamentarium, atropine. And taking the opposite side is Dr. Dipali Gogoi, representing one of the most exciting developments in contemporary myopia management, the use of defocus incorporated spectacle lenses. She will make the case that perhaps controlling childhood myopia need not begin with a bottle of eye drops, but with something as simple as child-friendly as the right pair of glasses. And to discuss these two sides and to ensure that neither side gets away too easily, we have Dr. Ankit Bhavsar as our discussant. His task is not merely to choose a winner, but to help us translate both arguments into the question every clinician ultimately asks, which child should receive which treatment. So over to you three, starting with Dr. Rishikesh, please.
Thank you, Dr. Vibhuti and team ARC, Dr. Parikshit, Dr. Prashant. Am I audible?
Yes, you are.
Okay. I'll just share the slides. My slides are visible, right?
Yes, Dr. Rishikesh, your slides are visible. You can
Okay,
convert
so
into slideshow mode.
thank you. So
Yeah.
I will start
Yeah,
with defending the atropine for control of myopia or reducing the myopia progression. As everybody is aware that myopia progression has been tried, or arresting myopia progression has been tried with different forms of treatment, out of which diluted atropine is perhaps one of the most commonly used treatments as of now. So there are three mechanisms of action how it works or believed to work. One is through the use of through dopamine. Second is release of extracellular matrix by the scleral fibroblast, and third is by increasing the choroidal perfusion. Whatever it be, it inhibits the axial elongation. So whenever we are considering any treatment for myopia control or myopia control strategy, it should be considered under the following points. One is it should have a strong clinical data to support its effectiveness. Because it is for a prolonged period of time in a child, it should have minimal or no side effects, minimal or no rebound phenomenon, or minimal or no plateauing effect. Also, there should be established protocol for the use, and also it should be cost effective, easily available, and it should be easily usable, especially in country like India. So whether atropine works for treatment of myopia progression, I think this is not a debatable topic anymore. Everybody is aware. This is the ATOM 1 study where they compared 1% atropine with placebo, but 1% cannot be used, so they went for lower concentrations of atropine, out of which they found that 0.01% of atropine has minimal side effects and is the best at the end of 3 years, both in terms of axial elongation and also for spherical equivalent dioptric change. So there was another study by LAMP study where they compared the effectiveness of different types of lower concentrations of atropine, and at the end of the 2 years what they found was that in terms of treatment and side effect ratio, 0.05% was actually good. All these studies were done in East Asia, so different ethnicities including India, they conducted their own studies, but at the end of it we found that there is a strong clinical data to support the effectiveness of low dose atropine for treatment of myopia. So what happens if we continue atropine for a prolonged period of time? This has been analyzed by meta-analysis as has been shown here, as well as a LAMP study which continued their treatment for over 5 years, and they found that at the end of 5 years a low dose atropine helps not only with no side effects or minimal side effects, but also to it doesn't have any plateauing effect, and once you stop it there is not rebound phenomenon with lower concentrations of atropine. Similar study by Dr. Rohit Saxena et al. At AIMS, they have done, it's not a 5-year study, but they have recommended that prolonged use of atropine can be safe, or it is safe even for high risk children where 0.05% atropine is used. So definitely long-term use of atropine has minimal side effects, no rebound phenomenon or minimal rebound phenomenon, and no plateauing effect. So treatment guidelines have been established based upon these studies, which have been published in IJO, in WSPOS and SPOCI. So we know which drug to be used, atropine, where it has to be used for simple myopes, and they have also defined what is the progression of myopia when you need to start treatment. Where they cannot be used is for pathological myopia, how long we have to follow up for 2 years, and then we have to consider how is the treatment. Atropine can be used for combination if alone it is not working, as already been mentioned by Dr. Rohit. So definitely atropine has established protocol for use. It is cost effective and easily available, and it is easily usable. So if you are using atropine, low dose atropine for treatment of myopia, you are doing the right thing, and actually atropine has revolutionized the way we are treating myopia progression. Thank you.
Thank you, Dr. Rishikesh. Dr. Dipali, please, with her side.
Oh, I'm sorry.
Dr. Dipali.
Yeah. Good evening, everyone. Thank you, ARC, for the opportunity. I am Dr. Dipali Gogoi, consultant ophthalmologist at Sri Shankar Deva Netralaya, Guwahati, Assam. And then I'll be speaking on the DIMS glasses.
Please do the slide share, Dr.
Sorry,
Dipali.
sorry, I'm not able. Yeah.
Dr. Dipali, I think your connection is slightly unstable, if you can check that.
Am I audible now?
Yeah, yes, absolutely. If you can share your slides, Dr. Dipali.
Yeah,
Any
yes.
problem?
Yes, yeah. Are my slides visible?
Yes, now they are.
Doctor, if you can just put it in the slideshow mode, please.
Yeah. Is it visible now?
Yes.
Yes.
Okay. So
Doctor, can you just put it in a slideshow mode, please?
yes. Sorry, sir.
On
Okay,
top,
so-
you have a slideshow menu.
Yes.
Top. You can just
Okay.
make it from
So
the
is
start.
it visible now, sir?
Can you just stop share for a minute?
Yeah.
Once you click on share, don't select
Yes.
the PPT, select the entire screen.
Entire screen, yes. Okay.
Yes. And then go sharing, please.
So it's not coming entire screen. It's coming as windows only.
When you click on share, the pop-up comes, just select the entire screen and then share.
Yeah, sir. After selecting the entire screen, the
And
share
then the
option
blue
is
button
not
that says share.
Vibhuti, otherwise let her do like last time and she can scroll down the slides. It's just a 3 minutes
Sure, so that's not a
presentation.
problem. Dr.
Yes.
Dipali, you can just
Yeah.
share your screen like the way you did,
Okay.
and we can see from there if it's becoming a technical problem.
Yeah, actually the share option, I don't know why it's not coming.
Yeah, you can continue with this.
Yeah, is it visible now?
Yeah, yes.
Okay. So about the DIMS classes, so it's a new innovation in the management of myopia. So it is actually the defocus incorporated multiple segments, spectacle lenses, a myopia control spectacle lens designed to slow axial elongation in children. So what are the DIMS lenses? In the DIMS lenses, there is a clear central zone which provides normal distance vision, and the surrounding there is a surrounding treatment zone which contains multiple small segments with plus powered lenses. The treatment segments, they create myopic defocus while maintaining the good central vision. It's developed for childhood myopia control. So the principle of action is the peripheral or treatment zone. It provides simultaneous myopic defocus, and the myopic defocus is believed to provide a signal that reduces excessive axial eye growth. The child continues to see clearly through the central optic zone, and the main target is reduction of the axial elongation and the myopia progression. The optical design, there are multiple small plus 3.5 diopter defocus segments that are incorporated around the central zone. The central zone is approximately 9 millimeter in diameter, and the treatment segments are distributed across the surrounding lens area. The design allows central clear vision with simultaneous peripheral myopic defocus. The evidence of efficacy, the randomized control trial in children with myopia showed significantly slower myopia progression with DIMS lenses than conventional single vision spectacles. Over 2 years, mean spherical equivalent progression was approximately minus 0.38 diopter with DIMS versus 0.85 diopter with single vision lenses. Axial elongation was also reduced, approximately 0.21 millimeter versus 0.44 millimeter. Long-term follow-up has reported sustained myopic control benefit. So the advantages and limitations. The advantages is they are non-invasive, so spectacle-based, so easy to use and preserves the central visual acuity. Useful for children who require spectacle correction, and limitations are adaptation might be required. Treatment depends on regular spectacle wear and also the cost effectiveness. So it does not eliminate myopia, but monitoring of refraction and axial length remains important. Clinical use and follow-up. It can be considered in children with progressive myopia after appropriate clinical assessment. Perform baseline refraction and where available axial length measurement. Emphasize consistent daily wear, and we have to review periodically for refraction, visual acuity, ocular health, and axial growth. Combined with healthy outdoor time and appropriate near work habits. In take-home message, we can see that DIMS, they are the defocus incorporated multiple segments where there is a clear central vision and surrounding myopic defocus segments. The evidence supports reduction of myopia progression and axial elongation in children, an important spectacle-based option for myopia management. These are my references and the studies from where the evidences are taken. And this is the schematic diagram of the DIMS lenses. So there is a central clear zone, 9 millimeter in diameter for distance refractive correction, and the surrounding honeycomb pattern defocus segments, 400 multiple defocus segments surrounding the central zone. Thank you.
Thank you, Dr. Dipali. Dr. Ankit, over to you.
Yes, thank you. Good evening. So my question to Dr. Rishik is that when you come across a patient with myopia progression, and if you give option to the parents about both the option, atropine and the DIMS lenses, so in which case you will insist the parents to start with the low-dose atropine drops, and you will tell them that DIMS lenses does not work for you, or you are the ideal case for the low-dose atropine treatment.
Actually, though I have defended atropine, I personally feel that I normally give both the options. Atropine as well as the DIMS glasses, irrespective of the financial status, because I personally feel that DIMS glasses are expensive. Not everybody can afford it as of now in India. Perhaps in due course of time it will. It becomes easier at least to start with atropine for many of these cases, and if the patients are refractory to the treatment of atropine, then we can switch over to the DIMS glasses. There are quite a few patients who can start as quite a few patients who have started with DIMS as their primary treatment modality for myopia progression. So I give both options to patients actually.
Thank you. So question to Dr. Dipali, that 6 years old child with around myopia of -6 diopter and strong family history of high myopia. So if patient is we want to prescribe the treatment, would you like to go with the DIMS lenses, or you will give the option of low-dose atropine, particularly 0.05%, because we all know that with DIMS lenses long-term outcome is not known yet.
Sir, actually, I prefer both. So I can give a combined therapy like that also, like we have given. So we prescribe atropine eye drops, 0.05 atropine eye drops to the patients, and we give the option to the patient that they can use both. So actually, for -6, it's better to use the DIMS lenses also for like along with his glasses. It will be incorporated in the glasses, so it will be convenient for the patient for the progression of myopia, sir.
So you begin with both modalities.
Yes, sir.
Okay, right.
So to discuss with some key points, so we always come across and a question arises. Primary concern is which modality is the superior and which modality to start the first treatment. Looking at the limitation, low-dose atropine has a rebound phenomena which is not noted with the dim lenses yet. And with dim lenses, there are very few studies with long-term outcome reported yet. So my personal opinion, we can offer both the options to the patients by doing proper counseling and considering various factors like compliance and financial status of the patient. DIMS lenses can definitely consider as a first choice and continue as a monotherapy for longer period. And also we should know that 0.05% low-dose atropine can also be started over 0.01% as a first choice in case of rapid progressor in the high-risk patients and the young patients particularly. But we should always keep in mind rebound phenomena and we should treat accordingly. Thank you.
Thank you, sir.
Thank you, Dr. Ankit, for summing this up.
Sir, please. Parikshit, sir.
No, I think let's go on to the next debate. We are running behind time because we have to keep some time for question and answers also later.
Yeah, so let's make it quick. So the next set of debate is multifocal lenses versus orthocal lenses, and we have Dr. Pawan, who will be talking about multifocal lenses. So most of us treat myopia, and this speaker actually studies why the eye becomes myopic. Dr. Pawan Kumar is a vision scientist, consultant optometrist and head of the myopia center at LV Prasad Eye Institute, with dedicated research training in myopia and ocular optics. When optical strategies are being discussed and debated, we have a true myopia scientist at the table. And to contest with orthocal lenses, we have Dr. Neha Yeravar defending orthokeratology, an approach fascinating both scientifically and clinically because treatment takes place while the child sleeps. She will tell us why corneal reshaping remains an important option in the rapidly expanding armamentarium of myopia control. And to moderate them will be Professor Rajesh Joshi. We will ask him to separate scientific enthusiasm from everyday practicality and help us decide whether these options really fit in Indian clinical practice. Over to you three, please. Dr. Pawan?
Dr. Kashyap, can you confirm that you can hear me?
Yes.
Thank you. Thank you for the introduction.
Yes, we can, sir.
Thank you, AOS, ARC, and Dr. Parikshit for inviting me to talk on this platform. So I will take you through the what, how, and why, and who are the candidates for the multifocal lenses, especially in relation to the myopia control. To start with, I want to highlight that the multifocal contact lens is not a new lens, but it is really old. And this is really old as the 1960s is when the first publication that's seen in the area of multifocal contact lens. Initially, obviously, it's meant for the presbyopic correction. On the right side, you're seeing the diagram of the multifocal contact lens. Largely, we talk about either center distance design, where you give this design for centrally for the optimal vision correction, and in the periphery, there is more plus. The second version is center near design, where you have more plus in the center, and in the periphery, there is less plus. What is it for myopia control? I think it's simply any distance center design or any D lens could act like a myopia control lens. There are different designs, but I think ultimately we are looking at a same goal of controlling the myopia progression or the axial length elongation. Now, within soft contact lens, we have something called simultaneous clear lens, or you have the extended depth of focus contact lenses, which are known to be widely used for myopia control. A second element is how these lenses actually work. There are various proposed theories, but one of the theories that's largely accepted is the inducing myopic defocus in the periphery of the eye. Now, I said this is a distance D lens, center distance. So centrally we have optimal correction. And as we go towards periphery, these lenses tend to induce more and more myopic defocus, which is known to help in controlling the axial length. The other philosophy is it provides the clear focus across the range of the viewing distances, largely distance, intermediate, near, and therefore the extended depth, or simultaneous focus for distance and the near viewing. The lens is also known to induce positive spherical aberrations, which is known to be debated for its effect in controlling the progression of myopia. Now, why are we really bringing this onto the table? Because of the good evidence that has been reported so far. Now, this is one of the recent living systematic reviews that we published in Cochrane, and highlighted box shows that multifocal soft contact lens shows similar efficacy to that of a low-dose atropine in producing the changes in axial length in 1 year and also in the 2-year duration. Overall, we look at in terms of 50 to 70% efficacy for controlling the axial length elongation. One of the good news is the multifocal contact lens, namely the MySight lens, is now an FDA-approved lens for myopia control. This is a report published more recently by the American Academy of Ophthalmology, which included 12 articles highlighting the efficacy and safety. I will just highlight the results, which shows all studies showed less myopia progression with these multifocal lenses compared to the single vision lens. And you look at the conclusion, which clearly highlights a generation of level 1 evidence for both controlling the progression and the axial length elongation. Now, one of the other challenges that we have in terms of contact lens is it really safe? Now, the same paper also highlights there are no serious adverse events when these lenses were given across multiple ethnicities involving 2 different locations. This is one of the very long-running soft contact lens clinical trial showing very good efficacy, also showing that this is approved by FDA for myopia control. Now, if you are wondering what happens in Indian children, this is the study that we have conducted at LV Prasad Eye Institute on the external depth of focus contact lens, giving it to children aged 6 to 15 years, and we found about 59% efficacy in regulating the spherical equivalent and about 50% efficacy in controlling the axial length. Now, coming to who are the candidates, I think anybody with myopia with progressive nature, I think are the candidates. Other things that to remember when you prescribe contact lens, they should maintain good hand hygiene. If they want to be really outdoor, worried about spectacles hindering their outdoor play for cosmetic reasons. And from the scientific point of view, anisometropia, anybody with unilateral high myopia, and parents if they're already contact lens wearers. I think these are my checklist if I want to really discuss about multifocal contact lens with the parent or the child. Now, also, we need to keep in mind if this is really a high cylinder, maybe that's not the case that we want to really fit multifocals, especially if there are large pupils, because again, that induces the positive spherical aberrations. Compromised fate, uncooperative child, of course, this comes with an expense. So we need to keep in mind about the expensive nature of these lenses. Now, there's a couple of cases that I want you to really look at. This is multifocal contact lens given to an individual who is 25-year-old, progressive nature of myopia only in one eye. Anisometropia, sports person, progressive nature. We gave a EDOF lens in this individual. You see that the myopia is pretty much in control all the way from 2021. They never had to change the spectacle for good 5 years now. And the axial length also pretty much in control. This is extreme high myopia, -19. We think, okay, -19, can I do anything? A lot of times we raise our hands saying, okay, it's hands up. But within 2 years, axial length increased by 1 millimeter, and that's when they were referred to our myopia center. We started to think, okay, can we do something? We said multifocal contact lens is available until -12. So until -12, we gave multifocal contact lens, the remainder in the spectacle format. So I called it as partial correction. And you see that in 1 year before treatment, it is 1 millimeter. In 3 years, with multifocal contact lens, it's only 0.6 millimeter change. So which means it's really worked great. Overall, I think multifocal contact lens has multiple advantages. It has to be a part of myopia management. Largely, if you ask me why, it gets to control and also the correction in one shot. There is good evidence out there to say that this actually works in favor. Various philosophies are known to be indicated for why, how it works, especially the simultaneous vision and also the peripheral myopic defocus. Who are the candidates? I think any myopic child who is keen and also progressive in nature can be considered for multifocal contact lens. With this, I thank you for your attention. Dr. Kashyap, over to you. Dr. Kashyap, you're on mute.
Hi, sir.
Yeah.
Pediatric ophthalmologist based in Pune. Dr. Neha, ma'am.
Still not able to share, sir.
Dr. Pawan, sir, you will have to stop sharing screen.
Yes. Is this visible, sir? Is my slide visible and am I audible here?
Can you see the share screen icon, Dr. Neha?
Yes, sir, but
yeah.
I have shared it, but I don't see it. Okay.
Ma'am, you will have to open the, yes. Now go to slideshow, start the slideshow also.
Yes, sir. Is it now?
Yeah, great.
Okay. On the outset, I'd like to thank Dr. Prashant sir and Dr. Parikshit sir for this opportunity. Going ahead with OrthoK, I would like to start with the basic of the structure of the OrthoK lens, which has a central base curve fitting right in the center, a reverse curve, basically the curve which helps us with the myopia progression, and alignment curve, which helps us with the centration and the fixation of these lenses, and a peripheral curve for the good tear circulation. So this is how it basically works, with a positive push force in the center and a peripheral negative pull force right at the alignment zone. This is how you see them being working, and then eventually the OrthoK lenses are also useful for a myopia progression, causing a peripheral myopic defocus. They work on the same principle of stopping the axial length elongation, causing this peripheral myopic defocus after their overnight wear. Now, selection of patient is any ideal child of 6 years of age, which is good and obedient, motivated parents because you need them for a better compliance and good hygiene. You can correct a refractive error of up to -10 diopters pair, -2 cylinder, and with a toric OrthoK lens that can be extended to 3.5 cylinder. Good lid laxity and partial correction, like Sir said, with a spectacle and an OrthoK can also be tried. Now, who will not be a candidate, which is good for this, is blepharitis patient, any lid issues, any kind of lack of thalamus, any severe dry eye patients, or keratoconus suspects. We do need to take into account unrealistic expectations because OrthoK will revert back once discontinued. The most important thing about OrthoK, because it's a contact lens, is the safety profile. I would want to highlight these 3 papers wherein OrthoK showed a very high safety as even compared to contact lenses. The incidence of follicular conjunctivitis was also way lower, and in a multicentric Chinese study encompassing almost 5 centers, 2,768 patients were seen with a very low incidence in the adverse effect profile. So Coming to the slide as to why Ortho-K is better than the soft contact lenses, the first and the most important point being a spectacle-free or a lens-free period in the daytime. Proficient myopia control. It is a non-invasive procedure. It has lesser chances of infectivity because of its nighttime wear, wherein the child is in a safer, controlled environment. No rebound phenomena seen even with increase in the near vision activity or screen time. Works very well with other modalities. Partial spectacle correction can be given even for higher degree of myopia. And with a good hygiene, we have seen Ortho-K lenses to have a good life of around 2 years. These are my studies for Ortho-K as a modality for myopia control versus the other modalities. You see almost equal or more effective modality control when it comes to DIMS classes. Similar cases with atropine. RLRL has definitely shown a higher profile, but unfortunately, like we've seen earlier, it's not available in India for now. As far as the multifocal contact lenses studies are concerned, yes, they have shown an equal profile. A few of them, although, have shown, especially with the systematic review that we see, an equivalent or better efficacy when it comes to axial length elongation. So, like the similar study which Sir quoted, the multicentric study, you see Ortho-K at a higher position than multifocal soft contact lenses, which have been useful for the control of myopia and its axial elongation reduction in the first year and the second. So this is my presentation. I would like to take you back to this slide and would like to say that, of course, myopia control is a very important part, but we have to take into consideration that it's a child and someone who has a very active sports life, a good quality of life. Like we've heard before, the peer pressure of wearing glasses or even lenses can be problematic, and a very good safety profile with Ortho-K gives it to be a good and contender in this control profile.
Thank you, Dr. Neha, and thank you, Dr. Pawan. Both of you gave very excellent presentations, and I think two things stand out. One is us ophthalmologists, especially comprehensive ophthalmologists, we think twice before prescribing contact lenses in children. But then, yes, contact lenses in children, multifocal lenses, Ortho-K lenses have their place in slowing down the progression of myopia. And as Dr. Pawan said, even for somebody as high as -19, there can be a combination of specs and lenses. And same as Dr. Neha said, Ortho-K need not be perhaps given full. And each one of them has a niche segment. And I think if we don't do it ourselves, at least we can refer it to our colleagues who do it, because we can help our patients in so many different ways. Thank you. Professor Rajesh Joshi is caught up in an airport, so he couldn't join. So he just gave me his thoughts to say. So can we go on to the next debate where we have Dr. Chintan from Sri Sadguru Netralaya Chitrakoot and Dr. Nilutparna Devri from Guwahati, Assam. Dr. Chintan, sir. And we have our doyen of pediatric ophthalmology, Dr. Sumita Agarkar from Shankar Netralaya, Chennai, who will be doing the discussions and who will be an arbiter between both of them.
Yeah. Good evening, everyone. Are my slides visible?
Yes, they are, Dr. Chintan.
Yeah. So thank you for this opportunity. And today I'll argue why atropine monotherapy is a more suitable option than dual therapy. I have no disclosure, no conflict of interest. So as a treating physician, we are not chasing some largest average number on some Excel sheet. Our goal is to identify single best, most sustainable treatment strategy for the individual child sitting in front of us. Now, I agree that dual therapy is likely to be more effective just like 2 or 3 anti-glaucoma medications would be more effective than a single drug. But the treatment must be risk adapted, response guided, and not automatically maximal. Now let's look at the evidence. Now we all know that the atropine monotherapy is already very efficient. The 2024 multicentric study conducted by Saxena et al. Showed that low-dose atropine alone achieves a massive 68% reduction in myopia progression. Now, if you ask about rapidly progressing myopes, then again we have study by Saxena sir, which showed that 62% reduction can occur with 0.05% atropine. So this proves that even before we consider adding expensive lenses, our primary medical monotherapy is already exceptionally powerful. Now I'll talk about the practical reality. Now the first part is economics. Now atropine is highly affordable and scalable across India. Specialized anti-myopia glasses impose severe recurring financial strain on families. Now if a child can respond excellently to a simple drop, how can we ethically justify compounding their financial burden from day one, which is very important in a country like India? The second point is treatment adherence. Now, the monotherapy relies on exactly one simple behavioral habit: a single drop administered at bedtime, and that too by a parent. A forced combination approach introduces a dual point of failure. Now, the glasses work, but if only work with the child wears them perfectly throughout the day. But we have seen that the active children often take their glasses off during sports, misalign them, or break them. Their entire real-world effectiveness of combination strategy can collapse. And third, the most important point is data clarity. Now, when you start with monotherapy, you preserve a clean clinical tracking window. If a child responds, then it's good. If it's not responding to the monotherapy, then we can increase the concentration or can initiate combination therapy ultimately. But suppose if you combine therapies from the start, and if child still progress by half a diopter in 6 months, you face a clinical blind spot. You cannot know which mechanism failed, leaving you powerless to safely adjust the care plan. But with the step-by-step approach, your data is clean and you know exactly when and how to scale up safely. So therefore, my definitive proposition is this: start simple, measure objectively, and escalate selectively. Don't overwhelm a child with extra treatment just to chase some perfect study numbers, because in the real world, maximum efficacy is simply not same as optimal care. Thank you.
Wow, that was very clear and succinct, Dr. Chintan. So let's see what Dr. Nilutpana answers to it. Can you stop sharing your screen, sir, so that the other speaker can start?
Yeah, thank you so much. Yeah, thank you, AIOS, for this wonderful opportunity. I'm going to share my screen now. I hope my slides are visible.
Yes, they are, Doctor.
Is it on the slide mode? Okay. I think the slides are. So thank you, Dr. Chintan, for the wonderful introduction into the pharmacology of myopia progression. So good evening, everyone, and respected madam and members in the panel. Today, I'm going to, tonight I'll be speaking in favor of combination therapy as primary treatment for myopia. So there's one problem here. Let me handle this. Just a minute. I don't know why this thing is coming just in front of my screen, but it's okay. So without much further ado, so I'll be talking about the combination therapy as opposed to, my slides are not moving. I don't know.
Just click on the screen and you should be able to move.
Yeah, is it moving now?
Yeah, perfect.
Okay.
Yeah, it is.
Okay, no financial interest in this presentation. So as we all understand that choroidal thickness can be used as an assessment for long-term outcome for myopia control as for atropine as well as the concentration titration. But would it not be a better or a beneficial beneficial for us to induce control defocus by the selection of lenses for these children? Because we all know that when you put in an atropine 0.01% drop, you can dilate the pupil by approximately 0.71 millimeter, which increases the effect of the DIMS lenses in the children. So now coming to the point that we are all measuring the spherical equivalent refraction as well as the axial length elongation in these children. The main question is that are these lenses efficacious even in different concentrations of atropine? Whether this therapy can be combined in all age groups? Do they work equally for the pre-myopes? What about the high myopes? Is there any strong clinical evidence to support what I'm saying now? And what about the real world setting? So if you look at the concentrations of various atropine formulations that are available, Chia et al. Has given a retrospective cohort study where they studied both low-dose atropine of 0.01 as well as 0.125%, and they showed that both the concentrations had similar effects on myopia control. However, young age was correlated with a greater risk of myopia progression. And when you talk about the preschoolers or the pre-myopes, we really do have a upcoming study, which is prospective multicentered study, which says that when you use a low dose 0.01 atropine with the DIMS classes, this trial will actually provide us insights into giving new care policies for early identification and intervention in these pre-myopes. So what about the high myopes, which are of high concern for us? So the previous speakers have already pointed out that in high myopes, we are also having some partial influence on the progression of myopia, both in terms of spherical equivalent as well as in terms of the axial length elongation. And you see in the baseline spherical equivalent of -6 diopters in these children, the change in axial length was significantly higher in the ATR group. So you are already seeing that these groups are already progressing as compared to the combination group. So we feel that even in high myopes, this has got some amount of influence of the combination therapy. Now the effectiveness in the real world. So when you look at the real world effectiveness, you will feel this study has actually gone beyond comparing only the combination therapy, not only with DIMS classes, but also with orthokeratology. And they have found that the DIMS A group fared well, both in terms of spherical equivalent as well as axial length elongation, up to 70 to 77% in this study, and where atropine monotherapy alone went up to only 62%. So one of the most important randomized control trials, that is the ASPECT study, has told us that it is the first RCT to evaluate 0.02% actually. And you see the inclusion criteria where the age group starts from 4 to 16 years, has got a very strong family history, and they also are progressors. And when you look at these children, they are from different ethnic backgrounds, and you will find that 4 out of 10 children achieved emetropic age matched axial length growth control over a period of 1 year. Now, the PRISMA also did a PRISMA analysis, a systematic review, also compared 8 studies. But out of these 8 studies, they studied 3 studies which compared only the combination therapy and your atropine monotherapy. And they found statistically significant reduction in the spherical equivalent as well as the axial length. Now, when you talk about ethnicity, we are all the studies or the data that have been provided even by my dear friend Chintan, these are all data that are persistent or consistent with that of the Asian population. So when you look at the Chinese population, you will see that the axial length elongation of change was measured along with the orthokeratology. And DIMSA proved that in this category, the axial length elongation was 0.13 lesser compared to that of the OCA or the monotherapy alone. So can we compare this with the European population? Yes, this study by Paulo et al. Showed that if you look at this group, combination therapy was most successful in myopia progression, even in the European population. So do you not feel that the synergistic effect of these lenses along with atropine provides more beneficial slowing down of spherical equivalent as well as axial length elongation in these children as compared to monotherapy alone? I do understand that these numbers do not count, but if you look at the consequences of progressive myopia, do you not feel that a combination therapy will give you a better result in helping these children? So therefore, I would like to say that it's not the adaptability or tolerance of only the drops, but it is also the defocus optics of these glasses that will help in the synergistic effect of controlling the myopia progression in these children. So thank you for your patient hearing.
Thank you, Dr. Nilutparna. If you can just stop sharing your screen so that we can listen to Dr. Sumita ma'am.
First of all, congratulations to both these very, very compelling and very beautifully presented talks. I think here we have to consider what are we treating. So we are treating myopia progression. We are not really treating myopia. So Nituparna's job, if you look at only effectiveness of the thing is, Nituparna's job is easy because there is not going to be any doubt about that key combination is likely to work slightly better. But 62 versus 70%, is it such a large difference? To subject the patient to start with a dual therapy as in a primary setting, I think I'm with Chintan on that. Probably if you are starting it in a primary setting, it's probably best to go with one first and then add combinations if required. Where would I start a dual therapy? Probably if I already have a very rapid progressor, where you can see documented there has been a fair increase in the number over a very strong family history of high myopia, where probably parents, grandparents, and it runs into family. In a very, very limited setting, probably I'm going to look at dual therapy as my primary modality of treatment. So I think both of them have very compelling arguments, but I'm with Chintan on this. If you are doing it in a primary setting, probably best to start with monotherapy. However, if it is a failed response to atropine or a failed response to a therapy, any therapy for that matter, probably combination works best. So in those settings, instead of going with monotherapy and not changing your approach is also probably not going to work. Thank you so much for both of you for giving a very, very nice presentation and nice points for discussion. Thank you.
Thank you.
Thank you, Dr. Sumita, for summing it up so well. Dr. Nilutparna, not completely in your favor, more in.
I don't think this should be
Actually,
a debate.
I am also in favor with Chintan. I am also in favor with Dr. Chintan only.
So we all agree on this. So great.
I think this debate should not have been on this point. It should be in a.
No, that's okay, ma'am. It at least stresses it again. The salience of low-dose atropine and controlling myopia progression.
Sure.
So we are running short of time. So the second is, this is not something which is promoted by any pharma company or by any optical company, but all of us know that spending time outdoors for lifestyle modification definitely has implications on myopia control. So we have two prominent pediatric ophthalmologists, young pediatric ophthalmologist, Dr. Sneha Batra speaking for, Dr. Shilpa Solansa speaking against. So Dr. Sneha Batra, ma'am, would you start sharing your screen?
Yes. I hope I'm visible. Okay, so good evening, everyone. My name is Sneha Batra, and I'm here to tell you why myopia is a childhood lifestyle disorder. So why is this question even being asked? Led me to think of this image. Would any of us want to be in the place of this patient or this doctor, where we are treating a disease without even understanding why this disease is occurring in the first place? So if myopia is not an environmental disease, then what is it? If we think it is purely a genetic disease, we just need to see how it has progressed over the last 50 years. Can any gene multiply more than 10 times in a span of 50 years, especially where the lifestyle of children has degenerated? So definitely there is a complex interplay of both genetic and environmental factors. If we think that children with myopic parents only are the ones who are more at risk, and definitely this is a statistically proven point, my question is, are myopic genes the only route of disease transmission that a myopic parent gives to their child? I think that a myopic parent also transmits their myopic lifestyle, not letting the child go outdoors and play, which helps to increase this myopia in the child. If we think that myopia is more prevalent among some ethnicities only, really increasing in the Far East Asian countries, we just need to look at this map once again. It is an epidemic which is going on in all continents. Just more or earlier in some continent than the other. And these are the countries which have actually caused a more academic pressure on their children, and hence they have gone through this at an earlier point of time. So what are the points that we are discussing today? Near work and outdoor time. These are two of the most important factors which can cause myopia progression. And what is the near work? Is any near work important? No. Multiple studies have shown that if a child is studying at a very close distance of less than 20 centimeters and for a continuous period of time, that is what causes this increase in myopia. And especially the digitalization of education, which really occurred during the COVID time. As Dr. Rohit Saxena sir had showed in his study, that more than 2 hours of digital education was the one which caused this epidemic of myopia during the pandemic of COVID. So it is really not education, but the digitalization and the modernization of education, which has caused this epidemic of myopia. What is the solution? Outdoor play. So there are studies which have shown that more than 2 hours of outdoor activity can help to balance the near work which is there. And why is it so? We give vision therapy, but going outdoors is a natural vision therapy where the child can see at all distances. The bright illumination which is available outside can never be recreated inside. And it is this illumination along with vitamin D and the dopamine which can help in myopia control. And these are the things which we use in strategies such as low-dose atropine and myopia control glasses, but they are really available free of cost in nature itself. As far as nutrition goes, there is very less amount of information which is available. But there is this important article from the Nutrients Journal, which showed that children who have an unhealthy lifestyle, they are not going outdoors and they are high on junk food, they are the ones who really develop this progressive myopia. And children who eat a very healthy diet, which is full of vitamins, proteins, and antioxidants, have a lower progression of myopia. Now, the only question which is really there to discuss, the IMI paper had this line which said that these environmental factors are more important in the onset, but not in the progression of myopia. The evidence there is a little less. My counterpoint here is, what is the onset of myopia? Is 0 diopters the onset of myopia? I think we all understand now that the progression of myopia really starts during the pre-myopic state, and it is the deranged emetropization. So myopia onset is already a progression of myopia, and all these factors are definitely very, very important. So I will sum up by this beautiful line, which was there in that same IMI paper, which said that a robust child, well-fed, enjoying a maximum of outdoor activities is less likely to get tired eyes and subsequent stretching of the cords of the eyeball and myopia than is a child that is cooped up indoors all day, sitting over lessons and never joining in vigorous outdoor games. And believe me, this was not said during the COVID time, but 110 years ago by Harman NB. And it is so very important in today's era itself. So if we really want to understand myopia progression, it is not a very complex thing. As Sherlock would say, it is actually quite elementary, my dear Watson.
That was very impressive, Doctor, the evidence that you have marshaled and so many different studies that you have got together. So that's a lot of talking points that all our ophthalmology friends will have when they see these patients in the OPD. Maybe now have Dr. Shilpa Sonar Khan from HV Desai Eye Hospital, Pune, to present the counterpoint. We can see the slides, Doctor. If you can put it on slideshow and start.
You are on mute, I think.
Dr. Shilpa, we can't hear you.
You're still on mute, I think, Dr. Shilpa. It's showing a mute in front of you.
Can you unmute yourself?
Don't just increase the volume. You need to go on that screen and unmute yourself.
At the left bottom corner, there will be a small icon. Or will it be possible for the administrator to unmute her?
She has to do, they have to do it themselves, sir. I cannot force them to unmute.
Just go from full screen so that you can access your screen, and then have your audio put on to speak. Just exit the full screen.
Doctor, can you just stop share for a minute first? There is a red button on the toolbar. Just stop share for a minute. First, unmute yourself.
Usually muting speakers is a problem, but
am I audible now?
Yes, doctor, you're audible now and you can start sharing and start speaking.
Okay. So, good evening, everyone. And at the outset, I would like to thank AISO-ARC for this opportunity. And I would thank Dr. Sneha for putting up her side. I'm Dr. Shilpa Sonarkhan, and I would be talking on do environmental and lifestyle factors affect myopia progression? And I would be debating against the motion. So let me start by saying that our debate is not about what is good for child. I'm not here to argue whether healthy nutrition, regular physical activity, outdoor time, healthy sleep are important for the child or not. Here the relevant question is how that these findings are specifically important in myopia progression, and that distinction is crucial because something can be healthy, biologically plausible, and even associated with a risk theoretically and still not be a proven treatment for myopia progression. And this is where our patients usually get confused. The danger comes when these complementary treatment, which are not completely proven, become the main treatment. And this we have seen time and again, be it the treatment for cancer, diabetes, or myopia. Imagine parents taking the outdoor activity advice so seriously that they don't take the actual treatment like atropine drops or progressive myopia control glasses, and the myopia continues to progress. That is not a complementary care, and it is a potentially delayed evidence-based care. So now let's come to the strongest argument on the other side, that is the outdoor time. And let me put some actual evidence in front of you. Outdoor exposure has some of the strongest evidence among lifestyle factors for reducing the onset of myopia, but not the same evidence in slowing the progression of myopia in a child who has already established myopia. Also, recent meta-analysis shows that there is no effect of outdoor activity in slowing the progression of a high myope child, and there is no effect on decreasing the slowing the progression of the axial length. And then comes the famous prescription of 2 hours outdoor every day. But we need to ask scientific question: is it 2 hours? Is it the amount of light? 1000 lux light, 10,000 lux light, or is it the UV exposure? Is it the physical activity, or is it something else about being outdoors? Or it may be just about adjusting the indoor lights and nothing to do with the outdoor lights, because until we know a precise dose, a mechanism, and reproducible effect on the axial elongation, we need to be cautious towards this, because this lifestyle advice should not be confused with therapeutic prescriptions. Now let's turn to Let's turn to the near work, and again we have to ask the right question. Does near work have an association with myopia? Probably yes, but clinically important question is, does reducing total reading or near work time actually slow progression once myopia is established? That is a completely different question. Longitudinal studies have given no clear evidence about this, and so yes, tell the children to take breaks and avoid prolonged near work, but do not tell the parent that their myopia is progressing because they are reading too much. This slide summarizes my arguments. Near work may be associated with having myopia, but association is not causation. And reducing near work may not automatically slow axial elongation in an already myopic child. We have to distinguish risk factors, disease onset, disease progression, and treatment response. These four are different questions, and evidence at one stage can simply cannot be transferred to another question. Then coming to nutrition, nutrition is perhaps where we are most vulnerable to overinterpretation. Vitamin D, micronutrients, macronutrients, and dietary patterns all are very interesting. But a nutrient can be important for general health, retinal function, ocular development, without being proven treatment for axial elongation and without a randomized controlled trial. Simple association from observational studies stand no ground. So what is the problem with all these lifestyle studies? It is that we sometimes make a much bigger claim than the study actually tested. We see an association, we find a plausible biological mechanism, we then recommend it as an intervention, and suddenly the association has become a treatment. And here the scientific nuance gets lost. So these are my references, and I would conclude by saying that healthy lifestyle is important, but evidence-based myopia control is a different question. Sensible near work habits are reasonable. Good nutrition is important, but when the child's axial length is increasing, we need to distinguish healthy advice from proven treatment, because हर चमकती चीज सोना नहीं होती और हर association causation नहीं होता. Thank you.
Thank you, Dr. Shilpa. That was very well defended. So may we have Dr. Siddharth Kesarwani, a brilliant pediatric ophthalmologist from Mumbai, who himself has a lot of primary research on myopia control, to discuss this.
Thank you, Dr. Gokte, for having me in the panel. In fact, I felt that this was the best debate till now, because both the parties really passionate about their standpoint. Nobody was conceding even each to the other party. So congratulations to both of you. And it's definitely a point to be discussed, because see, go to outdoors and play, and there are less of near work is all easier said than done, actually. And if we as clinicians, we are also parents, and we know that to implement our own children is so difficult, and it's so easy to give advice to other people, because it's the evolution of the social structure in the society and urban living which overall contributes. It's not a choice of the parent that their child should not go out, or their child should not eat healthy food, or their child should study more, but it's more or less become a compulsion for most of the people. Essentially, if you're asking a child to read less and outdoors more, that would almost be equivalent of telling the parent to leave the city and go to the village. Because these days finding open spaces and natural green spaces is a challenge, at least in a city of Bombay. Plus, when we are giving this advice, it is true that it is beneficial, but the devil is in the detail. What is the effect size of following this? It is also important to know that, okay, with great difficulty, if a child stops studying and starts playing outdoors and starts eating healthy food, what will be the contribution to his onset of myopia and the progression? That is important. So if you go through all analysis and everything, and do a critical analysis of the data available, you would conclude by doing all lifestyle interventions, all life. You are being the ideal good boy, you would probably slow down the rate of progression by 1 diopter for every 5 years. Okay, so that is the effect size small. When a child is progressing, and if he does everything right, still his rate of progression will slow down by 1 diopter in 4 to 5 years. So now for that you are asking him to alter his lifestyle completely, and that becomes debatable. Okay, but I agree that there are still many hidden factors. In fact, why these effect sizes are small in these studies itself is a matter of debate, because biologically they should have much higher effect size. So recently there was a paper in BMJ where they substituted these self-reported, time spent outdoors, etc., with something called as instrument variables. That means like having a dog in the family is an instrument variable for outdoor activity. Because if you have a dog, you will be outdoors, and then essentially a dog you will have to walk him twice a day, and then that means you are spending more time outdoors. So these are the kind of studies which show that the either though evidence that is there is actually underestimating the effect of lifestyle intervention. So there, Shilpa, your argument is probably because the studies are not capturing the reality. Okay, so maybe the self-repeated lifestyle modifications are actually overboard, thereby effect size becomes small. So there are a lot of things that can be debated, but I think you have started the debate. I think next time we should have a seminar just on lifestyle, because it's an interesting topic. Thank you so much.
Thank you, Dr. Siddharth, for putting all this in perspective. Let's go on to the last debate of sunlight versus red-free light. So we have Dr. Neelam Pawar, pediatric ophthalmologist from Arvind Eye Hospital, Tirunelveli, and for red light, Professor Rebecca Diman from AIMS. Go ahead, Dr. Neelam, ma'am.
Are my slides visible? Yeah, good evening. Are my slides visible?
Yes, they are, ma'am.
Yeah, good evening. First, I would like to thank AIOS ARC for giving me opportunity to speak on sunlight and myopia. So as we know that sunlight is very important for all the systems of our body and for the eye development, and insufficient sun exposure causes various health problems, myopia being one. And because of this, the countries which are facing high prevalence of myopia, they take sunlight exposure as a main myopia prevention program in their national myopia program. So there are evidences for and against the 8 facets of spending time in sunlight which can protect against myopia, that is brighter light, reduced peripheral defocus, higher vitamin D levels, differing chromatic spectrum of light, higher physical activity, change in circadian rhythm, less near work, and greater high spatial frequency energies. So white light, actually the term, it is misleading because sunlight and artificial sources, they activate the retina differently, and violet light has shown protective against myopia in experimental thing, and red light therapy has also shown, which is a longer wavelength, which is shown clinically good for myopia control in children, but there are concerns of the red light therapy, as there are few case reports which are showing foveal burn and subretinal fluid after RLRL therapy, and even a large study showing cone density changes after repeated RLL therapy in children with myopia. So how the sunlight works? There are proposed mechanisms that bright outdoor light and sunlight stimulates the retinal dopamine production, which inhibits the axil elongation, and also the other neurotransmitter are also affected, and outdoor activities leads to minimal peripheral hyperopic defocus, which act as a stop signal for the eye growth. And dysregulation in circadian rhythm happens whenever there is a lower daily sunlight exposure, which contributes to the myopia development. There are various landmark school-based studies, randomized control trial, and famous one is recess outside classroom intervention, that 11 hours in a week outdoor activity it causes 54% lower risk of rapid progression. And then there are various other population-based studies which are done both for prevention and onset of myopia and also for the progression of myopia, that increased time outdoor, it is significantly related to the myopia onset. And all these evidences of outdoor and sunlight recommendation led to the policies of National Myopia Prevention Program in various countries like Singapore, Taiwan and China. And Taiwan has this Tian 120 program which says that, and it is already implemented, that 120 minutes per day outdoor activities in school, it has done a reversal of long-term decline in visual acuity over 5 years. And not only the children, time spent outdoor in childhood is also associated with reduced risk of myopia as an adult when we see in cases of a young adult myopia progressor. So with the weekly outdoor time versus reduction in myopia onset risk, there is a non-linear dose response, and most of the pooled studies says that more than 120-minute per day exposure was the most effective in preventing the onset of myopia. So measuring light, why? Whether the same brightness isn't the same light, and the light, whatever that light exposure, it depends upon geographic latitude, season and atmospheric condition. In a same sunny day, the illuminance can vary from 20,000 to 100,000 lux, and in indoor even it is very less than 1,000 lux. And to measure this sunlight, various studies uses this luxometer. And how to measure this sunlight and outdoor time, it is very challenging. Most of the studies either uses questionnaire format or wearables or smart glasses. So again, this is a questionable how they are measuring this sunlight exposure time. And at the same time, when we are advising the sunlight exposure, we have to be very cautious with the skin cancer, pterygium, the higher incidence of this. But again, if the causal factor in myopia protection is visible light rather than UV, then myopia prevention intervention will probably be compatible with the avoidance of UV exposure. And again, there are studies which support that choroid, it's a dynamic structure, choroidal vascular blood flow is also affected by sunlight. And the interaction between the outdoor timing and reading time, and even various studies have shown that with this, the genetic risk of development of myopia can also be reduced if child is exposed to sunlight. And conjunctival ultraviolet autofluorescence, which is an objective biomarker of the cumulative sun exposure, it is significantly smaller in myopes. Now there are various Indian studies to support, because in India we will have again different, our environmental conditions are different, our classes are more compact. So these studies from LBPI group and SN group, they also shows that light has something to do with the myopia progression. And again, the debate is still whether the sunlight, whether it causes.
Can you sum this up quickly, Doctor?
Yeah, whether in progression in already in myopic eye it is effective. So besides our optical intervention, behavioral treatment is required for the pre-myopes, and nature doesn't require any FDA approval. And not any light, but light more than 1,000 lux is important. So outdoor sunlight should come into the policy and myopia prevention programs. Thank you.
Thank you, Doctor, for marshalling so much of evidence for sunlight. So may we have Dr. Dhiman present for red light, and then from very fantastic pediatric ophthalmologist from Pune, Dr. Nikhil Rishikeshi will do the comparison and the sum.
Thank you, sir.
Yeah. So I've started sharing my screen. So thank you, Dr. Neelam, for sharing your side of the story. But I think the previous presentation has made things really easy for me. So I would be talking in favor of RL therapy, although personally I do not have much experience, obviously because it's not available in India. But I think I would like to sum up all the literature which is there. And so what is RL therapy? So it's so basically it's your low level red light therapy and repeated low level that is being targeted on the retina. So what is it exactly being doing? That it is a home-based desktop device, very simple to use. And it is giving you, instead of that broad spectrum daylight, which has UV and other components of the light, it is just focusing on to the most relevant part of the light, which is for the long wavelength light, the 650 nanometer red light, which they are projecting on the retina. What's the time duration needed for it? Well, it's 3 minutes, 2 sessions per day, compared to 120 minutes, which Dr. Neelam just shared. So 6 minutes is still doable for our children who have high academic loads, workload. And of course, it's painless and non-invasive. Now, what's the mechanism? Well, sunlight and your red light both have very similar mechanism, photobiomodulation. So, and they are acting at 3 different levels, at the level of the choroid, at the level of the retina, as well as at the level of the sclera. So it's increasing your scleral rigidity, it's increasing the choroidal vascularity, and improving the retinal energy, so just to stabilize your photoreceptors and RP cells. So essentially, it's the neurochemical modulation that's brought about by nitric oxide and release of dopamine, very similar to what the light is doing. Now, if you look at the studies, so it's been tried. Now, remember that most of these studies are from China because this machine has been developed in China. The most common that is being used is iRising or iRising, whatever, however you pronounce it. And these studies from China, they have shown this is a randomized control trial that's comparing your RLRL your RLRL therapy versus single vision spectacles in mild to moderate myopia. Interestingly, at 1 year, they just did not achieve axial length stabilization. Rather, also 40% of the cases showed axial shortening. So a little hyperopic shift was noted. Another study from China focusing on high myopia. So there are 2 studies in this. Less than -4, less than -6, both diopters, both the cohorts have been studied. And in both the cohorts, axial length stabilization was achieved and axial length shortening in almost 50% of the cases. Well, not just myopes and high myopes, RLRL is also effective in pre-myopia. So while sunlight is mostly focusing on prevention, it has proven its role as therapeutic as well as your preventive. In pre-myopia, these few studies are coming up. As you can see, in the last few years, lots of studies have come up that it has reduced the relative risk of developing myopia. The incidence of myopia has been reduced. And what's important is you need to intervene timely. So earlier, the better. So this is one comparative study that has compared your RLRL monotherapy with the combination with Ortho-K alone, and atropine. So all the interventions, most of the interventions that we have just discussed has been compared in this study. And they found that the combination worked the best. And apart from that, if you compare the monotherapies, RLRL actually fared very well. And as far as axial length stabilization and your spherical equivalent progression is concerned. So all these recent studies are kind of, tipping in favor of RLRL therapy. Now, what exactly is it that it's causing that hyperopic shift? Well, a part of it is explained by the fact that it's increasing the choroidal perfusion, increasing the choroidal thickness, but not the complete part of the axial length shortening has been explained. So we are still unsure of what is the exact mechanism. I think even for any other therapy, we are still unsure how exactly these therapies are working. We do not have exact explanation even for atropine for that matter, or for sunlight. Coming to safety outcomes, yes, there are case reports, rare case reports, one of subellipsoid zone disruption, another of some cystoid spaces, macular spaces. These were reversible after stopping the therapy. Nothing that has caused permanent vision loss until now. Mostly what's been reported is mild discomfort and glare, and mostly after images that last for a few minutes. So I think that's an acceptable safety measure if we see, quite a safe option. Now, there are no head-to-head comparative studies between the 2 therapies, but that's what I have summarized, that outdoor sunlight essentially is helpful as a preventive measure. It's more of a lifestyle modification, but as far as the control is concerned, you need to give a therapy. And you cannot, even my child, I cannot commit 1 to 2 hours of outdoor exposure every day. So let's be practical. I think 6 minutes of a session versus 2 hours of outdoor exposure every day. Then the results, clinical efficacy has been proven in the studies that are coming up from outside India. And in logistical barriers with outdoor sunlight, I think was also discussed. It's weather dependent, requires UV protection, and a longer periods of exposure are required. Rebound has been noted with RLRL therapy. So most of them studies, they recommend a maintenance therapy that should be given rather than, suddenly stopping it. But a recent 5-year study has been published with RLRL, again from China.
Ma'am, if you can sum up quickly, because
Yes,
we still have
absolutely, sir.
the main
So,
saransh to do.
yeah. So the saransh is that definitely RLRL not just is effective in controlling myopia, but also as preventing the onset of myopia. It has been used in the all types of myopia: mild, moderate, severe, pre-myopes, and different age group. The range is broad. 2 to 24 years it has been tried and has given pretty good results. The safety also has been reported to be quite acceptable. So the important warning that I would like to give, that a lot of other machines are available in the market which may not be actually approved. So avoid the general red light machines, and you must focus on only the approved devices. Thank you.
Gokte sir, shall I go ahead?
Yes.
Okay. So lovely talks by both the eloquent speakers. Very, very conclusive. Very, very comprehensive. Both of them have their pluses and minuses, I guess. But because sunlight exposure and the need for it and availability of it is more universal, and it acts across all levels of myopia, not just so the RLRL acts more in the higher myopias is what has been noted, at least at the initial phases, if I'm not mistaken. And it acts, and that's because so sunlight effects can help myopias of all level. I think that is a big plus. You don't need any machines that don't need any standardization, because you can't standardize anything above than the sun. So it's already standard. One downside for sunlight, like ma'am has already said, Dr. Neelam, that you don't know whether you're really achieving that level of lux. So I believe it's 10,000 to 15,000 lux that is needed to release that amount of dopamine, which is going to go ahead and cause all the changes. So I don't know how many. So already geographically, madam has shown us the map. So that slight lack of standardization is there as far as sunlight goes with the machine, and but there are no side effects with the sunlight therapy. Whatever will be good effects. Of course, if you can achieve the luminous intensity, if you can achieve the 2 hours per day at the right time, and without all the ultraviolet radiations entering the eyes and causing macular problems, foveal problems. So I guess that's the only thing with the sunlight. Otherwise, that's more universal and safe, and it's older. Now this one is pretty new. Like I said, it's a 5-year data, and it's still in the evolutionary process. It acts better with higher myopias as noted, because the initial choroidal thickness in higher myopias is lesser. Yeah, and they're thinner. That is why the choroidal thickening was achieved earlier in the first 3 months, maybe 4 months, and that's why the results are better in the initial months. Then they hit a plateau, and there was a rebound after a year, like you already mentioned. In the lesser myopes or lesser degrees of myopias, the results were not all that encouraging initially. That also probably you've said. My problem is with the lack of standardized machines, which also you summed up in the last slide, because there have been cases where non-standardized machines have been used for research studies in China itself, and have caused, yes, and have caused burns, thermal burns to the fovea. My other problem is subfoveal choroidal thickness is one of the criteria that is used, and they are condoning it and really celebrating the thickening of subfoveal choroidal thickness. Now I don't know how that translates, how a retinal surgeon would look at that over a period of 5 years. Subfoveal choroidal thickening, I don't know if that's going to be a good thing later on. I mean, I don't know. It's just a query that I have, because anywhere, because it does cause perimacular and paramacular foveal retinal thickening as well, isn't it? So
Yes.
that is a slight problem that I have. What will happen after 5 years? Because thickening of the retinas, membranes, epiretinal membranes, is it going to translate into all of that? We don't know. But yes, primarily speaking, it is very encouraging. It is very exciting. Just the terms that say axial length shortening give
Yeah.
every pediatric ophthalmologist, just the thrills. But of
Fancy
course,
terms, yeah.
absolutely, because reduction of spherical error, equivalent and shortening of actual length. We've never heard these in 25 years, or people haven't heard it in the last 40 years. That is
That's why
encouraging.
I have no personal experience.
Of
It's all
course, yeah, and it
we have
hasn't come
some
to India
Chinese
yet.
studies, so
Yeah, it hasn't come to India yet. But those are the things I would be wary about, and of course, long-term studies are needed. But brilliant talks, both of you. Thank you so much, and thank you, Dr. Gupte, sir.
Thank you, Dr. Nikhil, for summing it up, because sunlight is something that is there around us all the time, but we still don't know how to make the best use of it.
Yeah.
So I would request Dr. Milind Kiledar, Dr. Kiledar sir and I, we are Guru Bandhus, both students of Professor N. Kulkarni sir, and Dr. Kiledar has been my squint guru. So over to you, sir, for summing all of this up, because there is so much of evidence that is out there. So how does a comprehensive ophthalmologist put that in practice?
Can you
Please
hear me?
distill it for us, sir. Yes, sir, we can hear you.
I have only 4 slides and let us go through it. So this is one meta-analysis which shows results from 9 different studies which have met the criteria from 2017 to 2024. And it says spherical equivalent refraction mean deviation of 0.14 per year and a mean deviation in axial length of 0.05 millimeters per year. Now let us count if a child is from 10 years to 20 years. I will achieve only a reduction of 1.4 diopters in 10 years with my atropine, low dose atropine alone. Now this is a meta-analysis from 2024 to 2026 about atropine, which as you see the dose increases, the effect increases highest with 0.05 and highest side effects also and highest rebound also. Now, as far as DIMS is concerned, 6 studies involving 1,224 children were included, and 80% of them were from China. This shows little higher reduction in the mean diopters, that is 0.37, and axial elongation also by 0.16. So this is about DIMS. Now compare this is a meta-analysis of over 9 studies to 2026, and the pooled result shows that it's a comparison between ortho-K group and the DIMS group, and it shows little edge for the ortho-K group over the DIMS group. So overall, looking at this picture for about 25 years now, and similar things happened during amblyopia management also. That surges about various drug therapies, ceticolin, levodopa, carbidopa combination came, and none of them proved the time test. So at this juncture, in my practice, I advise any of these therapies only if the patient is aware, if he asks about it. And what is my choice? It is a combination of atropine and DIMS classes. And usually they choose according to their ability to spend, whether they want to go for combination therapy or DIMS alone or atropine, either of these 2 things. So at this juncture, I don't proactively advocate all myopic patients to undergo any of the treatment because the evidence is not enough. I would say 0.14 or 0.25 diopters of reduction per year. I won't count. Being a LASIK surgeon for over 20 years now, it is equal to treat a -4 and -6. So that's what I would like to sum up in Saransh.
I think Dr. Parikshit, I think Dr. Milind, yes.
Yeah, Dr. Milind gave us a very good and great summary. Dr. Milind has a huge pediatric practice, but he's also a huge general ophthalmology practice. So yes, there are so many options that are available today in the market. available in academia and in institutes. But as far as general ophthalmologists are concerned, I think perhaps low-dose atropine, after that, the dim spectacles, and then yes, in a very small this, perhaps multifocal contact lenses, ortho-K lenses, and of course, nutrition and everything that goes with it, outdoor activity, sunlight, what you said, Dr. Dimon, about the new red light therapy. So each one has its own small niche, but I think low-dose atropine and perhaps spectacles, the dim spectacles, are something that almost all of us, if we see a child with progression of myopia, is something that we should advise. So we have it now open for question and answers. So if there are any, we would be happy to answer. Dr. Rohit Saxena, sir. Yes.
Yeah. For last 5 decades, I've been trying different types of contact lenses. In those days, we used to use micro lenses. These are hard lenses. I have been observing that after using contact lenses, not only the progression of myopia is much less, which was much less, but the quality of life, visually related quality of life was much, much better. And as far as amblyopia is concerned, nothing like contact lens. And when you talk about outdoor games, this is the contact lens. You try educate the parents, then you can try that, and it's a wonderful thing to provide excellent, proper image, best corrected visual acuity image. And
thank you,
that is
Professor
helpful for all
Deshpande,
the
sir.
things.
Yeah, thank you.
So, yeah.
Dr. Rohit Saxena, sir, a few last words, if.
Thanks, Parikshit, for a wonderful session. It was very interesting, and I would tend to agree with Siddharth that I think the outdoor talk was the most interesting. I would just like to, I mean, and kudos to Dr. Shilpa for defending something which is almost indefensible. And I would like to just point out, I'm very passionate about outdoor, and I feel that it is something that we are tending to ignore, and diabetes is a comparison which I always give. So I would say that in diabetes, when we say prevention, we say good lifestyle modification is likely to be more effective in preventing than therapy. Once a patient is diabetic, it helps because without uh, control of your glycemic intake and all, you're never going to be very successful even with insulin therapy. But just saying that, controlling your calorific intake is going to control diabetes, unlikely. Similarly, I would use a corollary for lifestyle modification. Obviously, preventing is it's very useful if the lifestyle modification starts early. But once the child is on the way to progressive childhood myopia, lifestyle modification is essential, but not the only intervention that can now stop him from progressing. So, I would always say lifestyle modification is underrated and more research should go. The doubts remain and must remain on the duration, the amount of illumination, and of course, how we can have a customized intervention for every child and change his lifestyle. But I would say all of us should discuss lifestyle modification as the first thing before we offer any intervention choices. But again, a wonderful webinar, and thank you, Parikshit, for getting the among the best from all over the country talking.
Thank you,
Thank
sir.
you, sir.
It was just I was defending my mandate, and yes, we have different
Yeah,
opinions, but being participating in a debate, you have to put your motion.
Yes, yes.
Thank you.
No, we are way past time. So one last one. Professor Jaspreet Sukhija, sir, as the chairperson, and Dr. Milind Keledar, sir. Just one this from you before we end.
Thank you, Dr. Parikshit. And no doubt, I mean, it's if this webinar is of interest to pediatric ophthalmologists and now probably more to general ophthalmologists as well. So it's covered just everything. My only take would be that all this literature, all these meta-analysis, I mean, you should just take it as a guide. The progression of myopia is unpredictable. Okay, every case has to be individualized. So your real world practice could be different from what is all described. Okay, they were described, okay, this population is different, you do this, that, but you're not going to find those cases like that. okay, you'll have a plethora of cases. And my only suggestion or tip is that individualize your treatment, customize your treatment, and see what is best for the patient.
Thank you, Professor. Thank you. Kiledar sir, just unmute yourself, sir.
Yeah, nicely said, Jasprit. And I would like to say the same thing. Even if you give some kind of treatment, it may not be completely acceptable to that child. I have had few children, they use the DIMS glasses for a few days only and they were unable to tolerate, or even atropine. So you may suggest, but they may not accept.
Thank you. Thank you to all the speakers, the panelists, the chairpersons, and thanks to Dr. Prashant Bavankure, his man Friday, Tushar, the AIOS and ARC for giving all of us this opportunity. So with this, I think we can close the webinar. Thank you. Thank you once more.
Great job.
Thank you.
Thank you so much.
You're doing an excellent job. Go ahead.
Thank you.